And we'll learn a 4-step coaching process and how to implement each step. So why coaching? Why the focus on this? It's because in our work through the TechRRT, we've recently conducted capacity assessments for community management of acute malnutrition programs in Nigeria, Ethiopia, and DR Congo. And all of these assessments have shown that health workers are very motivated by supportive supervision, and they find them useful. And even with supportive supervision, there's similar difficulties seen year after year in CMAM programs. And so really this initiative was born out of the need to kind of take a look at how we're providing support and capacity building to health facilities and what can best be done to improve this. And so these coaching tactics that we're going to learn today are really quite relevant to national health teams, district health teams, who do supervision visits. It's also very relevant as a follow-on to trainings, because another thing we realized during these assessments that we conducted were that people will receive a really good high quality training and then they go back to their own work environments, and there's a bit of a gap between applying what they've learned in the training to their sometimes imperfect work environments. So this is these are two of the situations where on-the-job coaching and the tactics we're going to talk about today are really relevant. And now we're using community management of acute malnutrition as sort of a vehicle of, demonstrating these coaching tactics, but really it's extrapolable to any program in any sector. They can use these same tactics. But today, because we're a nutrition-focused team, we're using examples from CMAM programs. So what is coaching? Coaching is teaching skills, knowledge, and competencies necessary for health workers to perform a specific job within their own work environment. It uses the regular or existing workplace tools, documents, and equipment. So there's no special tools, trainings, anything that coaching requires. It focuses on helping the person being coached to discover the answers for themselves. And this is really key. And as we go through this training, we'll discuss this a bit more, but it involves less kind of telling the person and more having discussions with health teams working at health facilities. So this is the difference with coaching. It's a process used to empower individual employees to put forth their best efforts. Coaching is based on asking rather than telling, on provoking thought rather than giving directions, and on holding a person accountable for his or her own goals. And the elements of coaching is it's quite interactive between the coach and the coachee, or the person being coached. It's very much a back and forth discussion. It's solution-oriented. It's finding solutions to challenges locally. And it's also very action-oriented. It's creating, initiating an action plan with health teams. And when we do this trainings for national health teams in different countries, we really focus on the difference of turning recommendations into actions, because it's clear a lot of people now do recommendations, but making those recommendations actionable and practical and realistic for the health team to implement within their health facility is often a gap. So why do we do coaching? Although there's a role for classroom training, obviously there's a very strong role for classroom training, some of the most effective learning is done on the job. And research has shown that adults are more likely to remember information they get through personal experience rather than information they get from lectures. And then for adults, the best learning tactic is interactive. They would rather be mentored or coached than lectured to. And employees in training want to know how what they learn will be applied to the workplace, and not just the workplace, but their own specific workplace and work environment. So there's a lot of benefits to coaching, both to the team and facility being coached and to the person doing the coaching. It improves their skills. Employees feel very empowered, and we've seen this in a few of the countries that we've done this in all 3 countries, that employees, after we do a coaching session, health workers and nurses feel very good and empowered because they come up with the solutions to their own issues as opposed to being told what to do. And that just kind of changes the dynamic and empowers them. Happier employees will have better performance and increased productivity. And then for the person doing the coaching, it's more economical because you're training on site over sending a bunch of participants to a training and running a training. You can customize the coaching to a specific work environment. And better performance actually leads to less work and effort by the supervisors because they have higher performance indicators, and therefore you have improved performance outputs. So there's a really simple 4-step coaching model. I'm sure many people who are working already in CMAM programs are implementing quite a few of these steps already. So it's basically like a routine, supervision visit or mentoring session where you introduce yourself and observe the work. And while you're observing the work, the second step is to identify strengths and challenges. And these 2 steps are really how things are done already. It's the third step that really is where kind of the dance really takes place, and that is initiating a plan. And that's where we really work with the health team to develop that plan together. And then the 4th step is to get a commitment and follow up. So those 2, I think, are a little bit different, to kind of really work with the health team to set dates for when they'll have things done and to make yourself available to follow up. And then just in the center here, we have be supportive and encouraging to create a positive work environment. So step 1, introduce yourself and observe the work. And the purpose of this is to create an understanding between the team and the coach about what is happening. And then take time, take a lot of time, spend time following the flow of work in the health center, look at each patient and their individual OTP charts or SC charts or SFP charts, observe a feeding, observe the work environment, review the stock room, review the monthly reports. Take a lot of time kind of looking at the details and noting the strengths and challenges as you do this. And so step 2, as you do this, you want to identify current strengths and areas for improvement or challenges. So you look at what is working well and you encourage the team to continue the good work. And then you note the areas of improvement that you have observed. And it's really important here to look at the why behind the areas of improvement, because so often we can leave a recommendation at the health facility, but if there's not an understanding of why this is the policy or why this is the process or why this is in the national protocol, then...
Michelle, excuse me for a second. I'm not sure for everyone, but you've gone quiet all of a sudden.
Oh, can you hear me now?
Yeah, that's better.
Okay, sorry, I must have shifted my microphone a little bit. I also see that someone has its camera on. I don't know if I can turn it off. Anyway, so step 3 is to initiate a plan. I don't know. If someone is listening and has their camera on, could you please turn off your camera?
I think I can manage it, Michelle.
Okay, thank you. It's just covering up part of my screen. So step 3 is to initiate a plan. You can work with the teams to discuss solutions to the challenges. And this is really where it's important to work directly with the team and where the difference between leaving a recommendation and making an action plan takes place. Explain why these challenges need to be addressed, what's the reason behind them, why it's important, and then apply tactics to improve performance using existing resources such as national nutrition protocols, materials at the health facility, different equipment at the health facility, but materials and resources that already exist. So part of these coaching techniques is, as we discussed a little bit before, adult learning techniques, but we're going to get deeper into this now. And so there's been research that shows that people learn best when they do, as opposed to when they hear or read or observe. And we're going to look at this cone of learning, which shows how much people remember based on what learning technique is used. So this is the cone of learning. And you can see if you're facing your screen along the left, you see the different methods of learning. We have read, hear, see and hear, say and write, and then do a task. And you can see how at the top, research has shown that people remember 10% of what they read, 20% of what they hear, 30% of what they see, 50% of what they see and hear, 70% of what they say and write, and then 90% of what they do as they perform a task. And then in the middle of the cone, there's the different kind of really training methodologies that we use during trainings. And so if you think of conducting a training, you're not just going to stand there and lecture. You're going to have a lot of group activities, group work, different things like that. And so it's important to kind of look at all of these and implement those same methodologies into the coaching practice. So there's reading text, listening to a lecture, looking at still pictures, movies, watching demonstrations, participating in a hands-on workshop, role-playing, a model or simulating real experience. And then the last one at the bottom is direct purposeful experience, where you go through the real experience. And this is the line where coaching sits. And as you see, the people who get support doing direct purposeful experience remember 90% of what they do. So then it's better implemented in their future work. So normally during a coaching training with national staff, we have them review the cone of learning, and then they take each of the learning processes and come up with kind of coaching techniques and strategies that's relevant to their work environment and their own resources that they have either in their country, in their district, or in their health zone. And so some of the examples from previous trainings, and some of these are repeated because some of them obviously hit more than one of the learning processes. But you can assign readings in the national protocol, read or review wall charts or technical charts that are up in the health facilities. For hearing, you can host group discussions to gather more information on the problem and discuss solutions. And this comes up a lot, and this is key and should always be done with coaching, presenting the strengths, presenting the challenges, and then asking what's behind the challenges. And we'll see when we get into some of the examples why that's so critical and important. Meetings with health center direction, and then you can do a lecture or a small on-site training. For seeing, you can do demonstrations, look at pictures in the national protocol or on the wall, or you can make a tool and hang it on the wall to kind of identify processes, scheduling, or different, policies that need to be followed. If you look at say, you can have group discussions, lectures, and meetings with the health center direction. For writing, you can have them write a new wall sheet, or you can together work on monthly reports or OTP or SFP or SC individual cards together on how to fill those out and how to improve errors in those. And then for do, obviously you can have demonstrations, you can have assisted changes like help setting up OTP room or rearranging a stock room, or you can create a tool together to use. And this isn't always limited to technical aspects such as, following systematic treatment and medicines to give. You can also create a tool that looks at staffing. Sometimes they're short-staffed, so you can create kind of a staffing chart or a staffing tool. It can deal with things like that as well. So then we talk a little bit about turning challenges into actions. And so this is just a really basic example. So a challenge is a hardship or a problem needing an effort or a skill to overcome. So you want to look at the goal, which is the desired result, the action, which is the process of doing something to achieve the goal, and then look at the challenge. What change do we want to see, and what steps need to be taken to see that change? And this is where a large portion of this coaching training that we do for national staff takes place, because so frequently people are used to leaving recommendations, and the recommendations are correct, and they're usually really good, and they usually do address the challenge, but they're not always actionable. They're not always so clear what needs to happen. So we really take time to, change a recommendation into an action. And just in this kind of basic example on this page, let's say that you're in a health facility and you see that the nurse is not taking proper measurements of the upper arm, the MUAC measurement. So the goal is to take the MUAC measurements correctly. And often the goal is what the recommendation that's left in, say, a supervision notebook or what's said. But turning that goal or that recommendation into actions, you can review the MUAC measurement techniques in the national protocol. You can demonstrate how to take MUAC for the coachee, and you can also have each person you're coaching take the MUAC and assist them as they practice. And as you see, those three actions are incorporating a lot of the different learning techniques into practice. And I know that often maybe one person is trained, say, on taking anthropometric measurements, and then they delegate taking measurements to other people once they get back from the training who aren't formally trained. So this is a way of kind of helping those people have an uptake of skills as well. So just to kind of demonstrate this, I have a little case study that I'm going to read, and then we'll look at some of the strengths and challenges and actions for that. And then we have a real-time coaching example of what happened during one of our deployments. So we'll go through these. So basically for this case study, you arrive at Congo Town Health Post and you find two health workers drinking tea. It's around 10 a.m. and it's on OTP day, but so far none of the caregivers have shown up with their children. You ask where they are, and one of the health workers leaves to make some phone calls and go out into the community to find them. While she is gone, you start to review some of the OTP documents. You notice that the room is not well set up. Half-filled boxes of RUTF are on the floor, the hand-washing station is far away from the health center, and the CMAM documents are not well organized. The register is available and filled out well, and it matches up with the monthly report. So you've done all your observing. And now, as some of the caregivers start to arrive to the health post for their weekly visit, you watch the health worker take MUAC measurements, and you notice that he doesn't find the midpoint, and the MUAC tape is upside down when he takes the measurements. He does take the weight accurately, and he gives each caregiver 14 packets of RUTF for the week, noting carefully the amount on the OTP individual card. He doesn't provide any instructions to the caregiver on how to use the RUTF and provides no nutrition education. So for those of you who have a background in CMAM, you can probably see already some of the strengths and challenges in this case study. So here's the example and the strengths and challenges identified. So the strengths were they have the register well filled out and it matches the monthly report, which is huge because that's often a weakness. The health worker properly takes the weight, and he filled out the OTP card well. He noted carefully all the measurements and the amount of RUTF that he gave each caregiver. The challenges were limited involvement with the community because people weren't showing up until they were actively found. Poor OTP setup, as you saw in the case study. It was the papers were disorganized. There were half-filled cartons of RUTF all over, and the hand washing station was far away. They don't take MUAC measurements correctly. In this specific country, they do have to find the midpoint for MUAC, and also the tape, the tape was upside down. And there was poor dosage of the RUTF. The nurse was just giving everyone a blanket allotment of 14 packets. It wasn't based on the weight. And then there was no nutrition education on how to use the RUTF or just in general. So if you look at the goals, what goals do we need to do with this challenge? So at this point, this is when we'd sit down with the health team and we'd talk to them about some of these challenges and we'd set goals together. So the goals that were set together are to improve coordination with the community, improve the setup of the OTP facility, hang some wall sheets, and we'll get into why later, proper MUAC measurement, proper RUTF dosage, and to provide nutrition education. So some of the actions using the cone of learning that are relevant to this case study is that you can work with and meet with community leaders to ensure the community is aware of OTP Day. You can create a screening schedule for the community volunteers. This was something that came up from discussions with the health workers that community volunteers weren't always available or aware, so creating a schedule might be useful for them. You can demonstrate the MUAC technique and have the health worker practice. You can review the national protocol on RUTF dosage, and here you can make a wall sheet on the RUTF dosage in relation to weight, so they don't just give a blanket amount to all the caregivers. You can review education messages in the nutrition protocol and make a wall sheet with those messages that they know, so that it serves as a good reminder on what to say. And then you can actually physically work with health workers to change the setup and organize the OTP area. So you can move the hand washing station to a more convenient place. You can help take stock of the RUTF and make sure they don't just, they use one box before they open another box of RUTF, and they're accurately recording how much they use. And you can help kind of organize the OTP charts and the different papers that were disorganized. Assisted changes are really important, and to kind of initiate some of these steps with the health team will help empower them to continue work, and it will also ensure that they really understand what needs to be done. And they'll probably really understand it because they're the ones that have come up with the actions. So now we have, as you can see in this picture, a real-time example of coaching that we did. This is during a coaching training, and this was done when the training team went to a health facility to practice their on-the-job coaching skills. So we went to a health facility, and the strengths and challenges identified. The strengths were that the waiting area was clean and covered from the sun and the rain. The health worker was present and had already been trained on CMAM. The OTP area had good wall charts and all the necessary materials. The RUTF was properly dosed, and the register was accurate and up to date. So already this health facility has a lot of good things going with them. And there were some challenges that we noted. Here are the challenges. They were not respecting the admission and discharge criteria. And during the discussion and the review of the OTP charts, it was because they were having trouble finding the target weight. They weren't finding the correct target weight. Caregivers were not returning for follow-up visits. They're not respecting the protocol for routine medications. The health worker does not have access to the RUTF supply. And this was, during our discussion, it was discovered that this was because these two, not respecting the protocol for routine medications and not having access to RUTF supply, this was in relation to the fact that the person running the pharmacy took the key with them and they weren't always present at the health facility. So we got the why behind what was happening with those two. They did not find the midpoint when taking MUOC, which was required in this country. And the individual OTP cards were not completely filled out. And so just for the purpose of this webinar, we're not going to go through all of these. So I put the top two in red. The top two are what we're going to discuss. So we worked with the health worker. This is a picture here of the health worker. And the first step that was taken was that we asked the health worker to show how they find the target weight and reviewed the OTP individual cards where target weight was listed incorrectly. And that's what's going on right now. And it was just a matter that she was looking in the wrong column for the target weight. And the second action was that we had a discussion with the health worker on how to ensure caregivers can show up for follow-up visits. And she had a lot of really good ideas. The two main ideas were to coordinate with the health worker and community volunteers in neighboring health posts to follow up with caregivers at community level. So we learned that there was an existing structure within the community. There were already community volunteers. There were neighboring health posts that could help out with that because she was alone running the OTP. And then we had a discussion with the health center director, and he agreed to hold a meeting with the community leaders to stress the importance of follow-up visits in the nutrition program in the community. And this was done at local meetings and by coordinating with individual households. So we did follow up on this, and the health center director did meet with some community leaders, and then there was an improvement in caregivers showing up on OTP day. So that's an example of kind of how this works. And I hope it's clear that really at the end of this coaching session, this health worker right here felt very empowered and she was smiling. And I think she realized that, you know, she wasn't going to be kind of told what to do or lectured, that people really listened to her concerns because the work wasn't easy. You know, she was alone running this OTP program and needed some support. And, you know, I think collectively we all came up with some really good solutions to some of the common difficulties that she was also experiencing. So the fourth step is to get a commitment and a follow-up. So just because a plan is developed doesn't mean the team will follow through. So some ways to ensure this happens is to initiate some actions with the team. And we did this in the last example by meeting with the health center director to discuss the issue with the lack of community involvement and lack of connection with the community. And some really interesting things came from that. Set a follow-up meeting or schedule a telephone check-in depending on the availability of transport and in-country resources. It's not always feasible to have, you know, supervision every month or coaching every month, or follow-up if you're doing coaching as a follow-up to a training to make 2 visits. But you can also schedule a telephone check-in to make sure there's not any additional questions or issues that come up and to see how their team is doing on the action plan. Make sure you make yourself available for any questions that arise. And then be persistent. Put in the time needed when you're there for coaching and follow through on what you say and do. So if there is something that needs to be taken to district or regional or national level, you know, you can do that and then report back to give the information to the health team. And then definitely hang a completed action plan on the wall of the health facility or health post, because that will help as a reminder serving on what dates they need to have these items done by. So how to apply this to your work? When visiting health facilities, you can incorporate some of the tactics from the cone of learning to make sure you're hitting to help people really remember, you know, not just lecturing or reading, but making sure you're demonstrating and, you know, using those tactics where they have a higher percentage of remembering things. Definitely involve nurses and health center staff in the discussion on the challenges and have them suggest their own solutions, because often, you know, each community is different. So individual communities will have their own solutions and individual health centers have different resources available to them. And then you can brief those conducting
Michelle, we can't hear you again all of a sudden.
Oh no, can you hear
There.
me now?
Yeah, now we can.
Okay.
So
Um,
just go back a few seconds.
Sorry, yeah. So the third one, I hope you got the first two. So the third one is to brief those conducting supervision visits in your country and how to use some tactics and some of these tactics in their work. And we hope that the capacity can be improved by using these tactics. So at the end, thank you so much. Now we're going to open the floor up to questions. And just before we take questions, there's two quick things I want to mention. One, if you want more information, we have our email here at TechRRT at internationalmedicalcorps.org. You can check us out at our website at techrrt.org or our Twitter account at TechRRT. And after this webinar, we'll be sending out a quick survey to see what you think and if you have any feedback. So the link is here, but just note that we'll be sending out a survey to you guys to complete via email. So thank you so much for your participation. And if there's any questions, you can tap them in the box so you can ask them verbally.
Okay, thank you so much, Michelle. We've actually got a few questions already from a few of the participants, so I'm going to go ahead and ask you those. Thank you for those who have shared questions. The first one is, you said that it's applicable in many instances, but have you had feedback from other cultures, geopolitical areas, say Central or South America? Leading question into coaching should be culturally tailored.
Yeah, absolutely. Thank you for this. And yeah, it has to be tailored to every local situation. And I think that a lot of the coaching, especially at national level, which is what we use this for, is that you follow the national protocols. You know, you don't do anything parallel. And it's one of the examples we mentioned was taking the midpoint when you do MUOC measurements. I know there's a movement now to just not, questioning whether that actually needs to be done. But, if you're working in a country where they recommend taking the midpoint, you always kind of follow that. And I think that there's definitely always different security contexts. I'm not sure about Central and South America specifically, but I think, following national security protocols and kind of looking at working these tactics into existing routine supervision visits, and definitely tailoring it culturally if something's not appropriate to make sure you understand and know the culture. And I think that's the link there with working with the national health teams and making sure that, they have a very active role in developing their coaching strategies and plans. Does that answer the question?
Please feel free to jump in and say more, but he said, yes, it does answer the question. Great. Okay, the next question is, how long should the coach observe before initiating a plan?
So it's a good question, because as you're observing, you're going to see things that aren't right, and it's a bit of a balance between interrupting the work and, using demonstration techniques to show what is right then. So, I think that usually when in the countries that we've done this in, when we go out with the training teams or with the people doing the coaching, there's usually kind of a natural moment. Obviously, if they're preparing a feed, observe the feed, see how that's done. Don't interrupt the feed. Don't stop the feed and say, okay, we need to sit down and have this discussion. So usually it will be, an hour or sometimes 2 hours. Usually there's a part where you might observe for an hour. You might, check in on seeing if they're taking the anthropometric measurements or doing a feed in the stabilization center. And then you might take time to look at the stock room and, review just on your own some of the patient charts. And then you can have a good time for a meeting. The overall goal of this is we don't want to be overly interruptive or disruptive to the work going on, as we know that, some of these health facilities can be very busy. But to, kind of come up with a time that is agreeable for the nurses, and you to sit down and discuss a plan. So usually about an hour, sometimes 2 hours is good to observe, and then you can initiate a plan and, go back and forth with demonstrations and that kind of thing.
Great, thanks, Michelle. Just to add, everybody is different when you feel that you've had a good view of what's happening in the program. Michelle has talked about CMAM programs, but maybe other program types are going to be different on how long it's going to take you. It depends what it takes to really get a good overview of everything that's going on in the program. Okay. Then there's another question coming from Charity. Please let us know if that was okay, or if you'd like to have a follow-up question to that. The next question is, how do you deal with bias on portrayed behavior during the observation step? Usually people behave differently when they know they're being observed.
Yeah, absolutely. But, some of the things that I always say is that and this is especially with CMAM programs, but I think with a lot of programs, especially health programs, is that the reporting sheets don't lie. And so people may be behaving differently, but you'll know if they really take the anthropometric measurements or not, because you can kind of see when you look at the individual sheets. This is why it's really important to spend time observing, because you can compare, oh, look at the weight, and then look at the dosage of RUTF. Is this correct? And so that's true. But, the issue is, in our experience in doing this in the countries where we have employed these techniques, overall health workers, they do want to conduct their job. And I know there's sometimes issues with, them not being paid or other issues that kind of impact their work as well. But the idea of coaching is to really make their work easier for them and help their work flow a bit better within their own work environment. And so, there's often things will come up, and they may be putting on their best behavior, but they're still going to, you're still going to, if they're measuring something wrong, or if there's, things that they just don't fully understand about the protocols or what they're supposed to be implementing, those things are going to come up. And I think this is also a really important thing to do in the beginning when you introduce yourself and observe your work, to say, we're not here as, reviewing your employment or anything like that. Like, we're here as a colleague, as an equal, just to kind of see what's going on and see what's working really well, and then to look at some of the challenges you're having and to work with you to find some solutions. So I know in a lot of countries there is a bit of a hierarchy between the person doing the supervision and the health workers, when they come. And during these coaching trainings, usually we are doing trainings with people who are at a higher level within the district health team. And so it's very important when training those people to make sure they kind of let go of that hierarchy, and don't make people nervous, and kind of, don't command. There's kind of a learning period there, to make sure that the health workers feel comfortable, being honest about what's going on. And, you have to say, you're not going to get in trouble. There's nothing, there's nothing that bad that's going to happen here. We're just looking to help you better facilitate your work, if that makes sense to everyone.
Thanks, Michelle. I do have one other thing to add to that on a way to kind of triangulate information as well. When you're observing a program, one of the important sources of information, I think Michelle mentioned this before, is being able to talk to the caretakers, users of the service, depending on what program you're looking at, and just have a relaxed chat with them can give you information to make you question whether or not this day is similar to any other day or not. But just letting a mother openly tell you their experience in the program can be quite useful as well.
Yeah, absolutely.
Okay. The next question is, this is all with the assumption that caregiver wants to properly follow protocols. Coaching usually leads to buy-in, but what to do when a worker is believed to not want to change or only changes while the team is coaching? So what to do then?
Yeah, I think this is a challenge, but this also comes in when, I think there's NGOs, and then there's the government, right? And like we were just talking before about not having the district health teams or the national government health teams be overly hierarchical. They also do have a position of authority. And so that's why kind of joint supervision visits between either local and national NGOs and someone from regional district health teams, however it works in whatever respective country, is really important because at the end of the day, this is a job. And at the end of the day, really, it's the beneficiaries and the caregivers and the kids that are being helped. And the changes that will come about for this coaching are really changes that are going to benefit everyone. They're going to benefit the community, and it should also really empower the health worker. Oftentimes when we've been doing this in the countries where we've worked, we'll show up and the health worker will be kind of quiet or have a little bit of a guard up. But as we start the discussion and as that health worker realizes that they play a really crucial role in coming up with solutions to these challenges, they do feel quite empowered. And we never ask them to do something that's not realistic within their work environment. And there are things that are completely unrealistic that aren't going to be possible. Like if there is no community volunteers, we can't expect that health worker to go out into the community and completely run the health facility. So maybe this is when you have to meet with health center direction and make sure that the action plan is really realistic for that health worker and the demands aren't being put on the health worker. And as you saw from the example that we had, the real-time coaching example, that health worker, the woman, was alone in running that health facility. So we had to be really conscious of the fact that we couldn't overburden her or create too high of a workload for her that wasn't realistic. And that's when the mention was to coordinate with health posts that were kind of under the umbrella of that health facility to kind of help reach the community and to coordinate even with community leaders. So that person needs to know that they're not alone. We're not going to add more work to their workload, that we're actually helping them facilitate to kind of improve and streamline their workload. So I think it's very important to be conscious and cognizant of that health worker and to really empower them. This is when it comes when you kind of ask rather than tell. They come up with their own solutions to these problems, and then they'll be more empowered to make a change versus if we're just kind of lecturing or telling them what to do. Does that make sense? Can you guys?
Sorry. Sorry. So yes, that was very good, was the response. The next question, next question is, coaching a certain job is not that much difficult, but everyone should consider, is that commitment health workers to accept and perform activities in timely manner. So how can we manage this issue?
Yeah, so I think there's two answers to this question. Number one, like I said in the response to the last question, it's very important not to overburden the health workers and to make sure the demands, the solutions to the challenges that we come up with, A, not only come from the health worker, but B, also don't overburden or create an unmanageable workload for that health worker. So that's critical, right? Because as we discussed, it's very easy identifying, especially if you're an expert in whatever area you're coaching in, it's very easy to identify the strengths and the challenges and what needs to be done. But catering what needs to be done to that specific work environment, to that specific health worker and their skill set within their available resources is really key. And then performing the activities in a timely manner. This is where the fourth step comes in with follow-up, creating that action plan, putting realistic dates on when things will be done, and then leaving your phone number or just taking 15 minutes, on the dates that you have given that health worker to put in a phone call and say, hey, how's it going? To kind of really establishing a relationship with that health worker. If you are the coach or if you are the mentor, and it's realistic if you're conducting routine supervision visits, this can be done on follow-up visits, whether they're quarterly or monthly, or it can be done via the telephone, just putting in one phone call to follow up on this and kind of remind them. And this also works with, well with coordinating with local district health teams. because they do have, some authority as supervisors of the nurses, if that answers the question.
Great. I'm sure we'll get feedback in a second. In the meantime, the next question. For the observation phase of this coaching exercise, have you used a checklist or some other prompt to guide the observations?
Yeah, so I think we have actually, with this coaching, we actually have worksheets um, for every step for the observation. It depends on the country for the checklist, because already we don't want to duplicate things that already exist. So in some countries, there's already an existing supervision checklist. So that can be something that's used, because really it's just doing the plan that's different, right? It's making an action plan as opposed to recommendations. That's where the difference really takes place. And we don't want to give them two checklists, one that they already have to do for the government for supportive supervision, and then one that they have to do for their coaching, because we also don't want to overburden, we talk about overburdening health workers. We also don't want to overburden those people doing supportive supervision. So really, coaching is about using the existing resources. So I think if there is already a supervision checklist that goes along with the national protocol, to use that. If there's not one that exists, during the coaching training is time to kind of create one with the participants, or an NGO or the government can work together. The national nutrition teams can work together to create one if that's indicated. Because that is really helpful. But for the full coaching training, we do have kind of action plan worksheets and strengths and challenges worksheets that they can fill out if that doesn't exist in country.
Great. Okay, the next question, and for the moment it's the last one, and maybe there's another one that's just come. What is the best method for government health workers working for pastoralist community mobile populations?
Oh yes, this is coming up quite frequently. I'm sure Andy and probably a lot of people can attest to this. Pastoralist communities are quite hard to target. Um, and I think it depends on the strategy used to target these communities within the country. I think some countries, maybe they do mobile health teams. I know there's been talk of giving people who are pastoralists cards so they can go, to different OTPs within their region, that they don't have to always go to one OTP. So I think that this is really, it's really on a case-by-case basis. The coaching tactics will be the same, right? Because government health workers will be coached in the same way. And so really it's just kind of, even during the coaching training, this can be discussed to come up with a solution locally. But I know that this is a big challenging, and I think that there is even a movement globally going on now to kind of ascertain the best ways to work with pastoralist communities and to target them. That's not a hindrance. So I know some of the tactics that have been discussed are to allow pastoralists to go to, different health facilities in that region on their OTP day or for their weekly visits, to give them their cards. Though with reporting, that does pose a challenge. Having mobile clinics, that are kind of in the far out places to reach this mobile, communication via cell phone is also quite helpful. But I'm afraid I don't have a perfect answer for this, because I think that there's ongoing challenges to this. But I do know globally we are working on some solutions to how to best target pastoralist communities. So stay tuned for that. I don't know, Andy, do you have anything to add for that?
No, I'm sorry, I don't have anything to add either. You're hitting upon one of the most difficult things or challenges that I think we've been facing for some time.
Yeah.
So, in fact, perhaps the person who asked that question, it was, hang on, Kasim. Yes, Kasim. Maybe, do you have any suggestions on things that maybe have worked for you? Feel free to unmute yourself. Okay, Kasim, maybe you don't know how to unmute yourself, or yeah, you are still there. I'm going to unmute you so that you can speak. Just one second. Okay, one sec. I'm not sure if it's working. Oh. Okay, Kasim, looks like you've lost your microphone. Are you there? Feel free to write as well. Okay, if anybody else has anything that they would like to add to that question, open that up to anyone, because I think many people have had experiences with pastoral communities. Does anybody have anything they would like to add? Okay. If not, then does anybody else have any questions? I think we've come to the end of the questions that were in the chat box. I have a few things if we're finished. I see. Okay, great. Thank you for that feedback. We just had some positive feedback on the webinar. Okay, before we leave, I have a few questions for everyone. First, at the beginning of the webinar, Michelle had mentioned about a survey at the end, and you see it up on the screen right now. I'm going to send the link to this Survey Monkey. It's very, very quick. It shouldn't take you more than 5 minutes. It would be wonderful if you could pop into the Survey Monkey to just give us some feedback on the webinar. It always helps us to make it better. Any problems with even if it's technology or whatever, if you have any ideas for additional webinar in the future, we welcome any information that you like. Also feel free to send an email to the same email that you used earlier. That's perfect. One other request I have for you, if it says closed, okay, I will, 1 second, I will see about sorting that out in just a minute. In the meantime, if you can, I will fix that. Oh, wait, hang on. Maybe I can open. All right. I think I'm opening it now. Try again. If you don't mind just checking right now, I think that it should work. Great, fantastic. Okay, then the final question that I have for you, I need to, for one of our project indicators that we follow, is we like to know how many participants we've had that come from local or national organizations. If you can pop me a line either in the chat box now, if you're from a local or national organization, or send me an email, that would be much appreciated so that we know how many of our participants were. There is a question. Okay, no, Michelle has just said that we will share the slides and the recording with you later. I apologize in advance that I started the recording a little bit late. Just as Michelle was starting, I forgot when I started presenting myself. But I think that means you'll have the bulk of the actual content of the webinar, so hopefully that's okay. Otherwise, if there are no more questions, I just wanted to say thank you to everyone. There's one question. When is appropriate to collect the stunting indicator? I'm not clear on actually what the question. Can you expand on your question? Or Michelle, do you understand what's being asked?
You know, yeah, maybe you could expand upon it. I think, unfortunately, through routine CMAM programs, the stunting indicator isn't collected, the height for age. Yeah, I'm not necessarily sure about the when. I think maybe we should advocate to kind of start collecting that data. If doing smart surveys, that data is published.
Judith, are you talking about during CMAM programs or otherwise? I'm going to unmute you. I can. Yep. Go ahead, Judith. If you want to talk, you can. CMAM programs and other nutrition programs. Okay, one thing I can say is that the more we can collect on height, on stunting, the better, because it is becoming clearer that when a child is stunted and wasted at the same time, it does have implications, long-term implications. I'm not really fully up to speed, so maybe somebody else can add here. But the outcome, the risk for the child is greater when they're concurrently wasted and stunted. if anybody else has something to add, that would be welcome.
Yeah, and I think here, this is kind of where some advocacy can come in, because we're already taking height and we know the age of the children, during CMAM programs. And so maybe to kind of advocate if they're redoing the National Nutrition Protocols or redoing the OTP charts or the SC charts, to kind of just put a column in there that says stunting, so we can note who's stunted and who isn't. That could be interesting, just as a brainstorm.
And should we monitor it on a monthly basis, quarterly, or annually?
Yeah, stunting is hard because it's really not reversible after 2 years of age, do they say? I think it's even only moderately reversible before 2 years of age. So I don't know that there will be a huge change in stunting. Again, I think that this is something that would probably be done on a country by country basis and could be brought up with like the nutrition cluster or the nutrition coordination mechanism. Yeah, but I think it would be kind of interesting to look at how to kind of target to prevent stunting even within the context of a CMAM program. So thank you for these interesting questions.
And just to mention, for the questions that aren't answered, I don't know, I'm getting an echo now. Wait, hang on. Okay. I think these kind of questions, like the pastoralist one, as well as the stunting one, these are questions that we can gather and bring to the global technical mechanism to be able to see how these kinds of questions can be addressed more thoroughly. Okay. Yes, somebody needs to mute. I'm not sure if it's you, Michelle, but I don't think so.
I can mute.
Okay, with that, if there are no more questions, I want to thank everyone for the time they've taken. Please do try to fill out the survey. And I apologize if we've booked an hour and a half and we haven't taken the full hour and a half, but it depends on questions. And we prefer to have a little bit longer than lesser, to make sure that we cover everything and everyone gets to ask. Great, wonderful. And thank you for your time, and we hope to see you again in the future on another webinar.